Hi, Suraj. How are you
Yeah,
doing?
I'm good, thank you. How are you?
I'm fabulous. Looking forward to today's chat.
So am I. So for anyone that doesn't know, I'm Dr. Suj. I'm a GP and emergency doctor, and this is our first collaborative Instagram live. I'm here with Dr. Chetna Kang, and I'll let you introduce yourself.
Yeah, well, I'm Dr. Chetna Kang. Those of you who follow me, you know I'm a consultant psychiatrist. And yeah, both of us are here at your service with, ready to answer your questions. But I think, Suraj, you wanted to kick off with a few you already had, right?
We're going to jump straight into the deep end. Let's talk about ADHD. So,
Okay.
what is it to begin with?
So ADHD, it's an abbreviation, shorthand for attention deficit hyperactivity disorder. I think everybody's talking about ADHD these days, all generations. You know, I remember back in the day, people would refer to it as the disorder, which is for, little boys who are running around uncontrollably. And now we're getting a much more diverse, um, type of patients and even people talking about it. I mean, I get messages from even people in their 50s, 60s, and 70s wondering if they've got ADHD. So it's certainly a hot topic and of great interest to people these days.
Why do you think it's become such a hot topic in it's actually just recent years, isn't it?
Yeah, I would say actually it's probably become much more talked about since we all came back from all the COVID lockdowns. So I would say since 2021. So the last 2, 3 years, we've been talking about it much more. And in my clinical practice, I've certainly seen that reflected. I'm getting a lot more adults, and particularly female adults, coming to have an ADHD assessment or potentially also autism assessments. Because I think what's happened is, one of the key things with ADHD is that there is attention deficit, there's hyperactivity, there's impulsivity, and sometimes these things don't manifest because in earlier life either the symptoms got missed or there were things that buffered or masked the impairment. For example, things like your own personality type or internalized hyperactivity or actual masking, social masking, which women particularly do. The other reason, and it's a really common reason, is you may have been brought up in a family where there's a lot of structure. Your school may have been particularly structured. And often the adults that I see, male or female, often have a high IQ, which kind of floats them up until a certain point. And what happened during the lockdown is people were left to their own devices. They didn't have those structures that are organically there in education or at work. And so they started noticing the deficits that come from having ADHD. So I think it started becoming much more talked about. And also social media made our world in such a small place. People start getting on, on their various platforms, talking about their challenges. And before you know it, there's a trend around ADHD, and it almost seems like it's more prevalent than it's ever been before, and that everybody's got it.
You mentioned internalized hyperactivity. What do you mean by that?
So hyperactivity, hyper means excessive, and activity, obviously, what you do. So most people relate hyperactivity to something that's excessive physical movement, but really that hyperactivity is excessive need to or a compulsion to move physically. Now that can be tempered. So because it can be tempered either by society's expectations or your own internalized ideas around how much you are or aren't allowed to display your desire to move, have physical energy, express your physical energy, you may internalize it, and then get experienced more as a internal restlessness. So yeah, I mean, all three of these parameters, to be honest, if we just stuck to this topic for this session, we would fill more than an hour. But this is the thing. This is one of the aspects of masking with ADHD is some of the impulsivity or compulsions that one might have. One might, then start to internalize. So you're still experiencing it, but it's not manifest to other people. And one thing I want to point out to people is that ADHD is a disorder of regulation. So as you know, regulation happens primarily in the front part of our brain. So that's where all our impulses are regulated and controlled. So this regulation is off. It's managed by many different pathways, but one of them is the dopamine pathway. And what happens is, because it's a disorder of regulation, that means the regulation around your attention, your focus, stopping and starting activities, your emotional regulation, your regulation around your relationship with time, with space. So not noticing mess or when things are out of place, or not being able to keep track of time the same way someone without ADHD might be able to. So maybe trying to cram too much in a short space of time, or not realizing when time has gone by, and you think it's only 5 minutes when 2 hours has gone by. So all of this disorder of regulation is really what underpins the symptoms of ADHD.
It sounds like the things that you're saying though would be probably be relatable or related to by quite a lot of people who may not necessarily have ADHD. So how can someone differentiate between whether what they're experiencing is a variant of normal or whether it truly is a manifestation of ADHD?
It's interesting. In mental health, there seems to be a lot of pressure for people to self-diagnose. We don't have this pressure in physical health. If somebody has an unusual lump, bump, pain, feeling, they will go and get it checked out, right? But when we have unusual experiences with our emotional health or mental health, we don't want to get it checked out. There's still a lot of stigma. People would much prefer to figure out what's going on. And to be honest, to this day, I haven't fully figured out why. Some of it is definitely stigma. I think some of it is also partly we are still very much invested in believing that the mind is the seat of the self and that's who I am. When actually that's another subject of conversation, but there's a whole host of research which actually, really talks about and addresses how consciousness isn't just something that belongs to the mind and the brain. But this whole idea of why or how do people know whether they have ADHD, because so many people can relate to the symptoms. So first of all, I would say that one of the things to bear in mind is that when we make a clinical diagnosis, so this is the thing, we don't expect people to be able to figure out when they have ADHD. The same way people can't usually tell whether they have clinical depression or regular sadness, whether they have an anxiety disorder or day-to-day worry. Often people get muddled with the two because our level of tolerance is different, right? What our distress tolerance levels vary. And what we get used to also varies. So what I would say is when you're looking at the symptoms online, doing these screening questionnaires, etc., remember that a screening questionnaire is a screening questionnaire. It's going to focus on particular symptoms, whether you're experiencing them, but not really look at any context. So when you have an ADHD assessment with a psychiatrist like myself, for example, you will have a full psychiatric assessment as well as an ADHD assessment. Sometimes they're done separately, sometimes they're done combined. And I think it's really important to make sure you get that full evaluation, because the symptoms of ADHD, some of them can mimic and overlap with and even seem like they're from ADHD, but they may be coupled with other symptoms so for example, emotional dysregulation, you also get that in some personality disorders. You also get emotional dysregulation in other mental health disorders like bipolar, but it's coupled with other symptoms. You can also get in agitated depressions, you can get that emotional dysregulation. So, and again, attention and focus gets thrown off when you're anxious, right? Ask anybody who worries, even if you don't have an anxiety disorder. If you're worried about something, it's harder for you to pay attention. Don't you find you're clumsier, you drop stuff, you become a bit more absent-minded, especially when you've got a lot on your mind. So I think it's really important when you do a screening questionnaire or when you watch a podcast or a video, whether it's an expert or an expert by experience, right? I think it's important that, yes, there's a difference between being able to relate to someone's experiences and symptoms versus having the condition. The other thing is, as well as having that whole complete assessment, and don't be fooled by cheaper assessments where you just have the ADHD assessment and you don't have the rest of the psychiatric assessment, because you're not getting an accurate picture there. And as well as the assessment, remember, part of the assessment also includes looking at how long it's been impacting you. Has it been there lifelong since childhood? Is there anything else going on right now which has made this episodic, or that your symptoms have gotten worse recently, whereas usually they're manageable? So it's really important to understand ADHD is a neurodevelopmental condition. So it's been there since childhood. It's not just something that pops up later in life. And if you're finding it's popped up later in life, I'll tell you one of the most common things I've seen is during that lockdown period, because people lost their sense of regularity around eating, sleeping, their digital time. There's almost like the brain got rewired into dysregulation, and even spending a lot of time on screens. When we're on a screen for a long time, whether it's for entertainment, work, etc., remember, any digital screen, especially on a particular site, you're bombarded by thousands of images, sounds, stimuli at the same time. So the brain starts getting used to being scattered, right? And that can also mimic that, oh gosh, I've got to, almost have lots of things going on at the same time to be able to pay attention. And then people think, oh yeah, I must have ADHD. But you watch, if you actually take a good detox from digital media, you'll find that regulation starting to come back and that ability to stay focused. So just to summarize, my really long answer to your question is, if you think you can relate to some of the symptoms, rather than trying to figure out whether you have it or not by watching piecemeal things here or there, actually do go ahead and get an assessment, because it's more likely that you don't have ADHD rather than likely that you have it. Remember, it's a disorder. It's still, even with the, current levels of its prevalence, which we estimate between 7 to 10% of the population. So remember, that's the vast majority of people don't have it. So you're more likely to be in the vast majority who don't have it than in the 10% who do have it.
And then even the people that do have it, surely it would be a spectrum as to how affected by it they are.
Well, no, so this is the thing. In order to get the diagnosis, as well as having the symptoms of ADHD, you have to have a certain proportion of them lifelong, and it's got to impact a minimum of 3 areas of your life. So It's not just, it just affects one area. I mean, I get patients who have ADHD where it affects all areas of their life. It's very clear for me as a clinician when someone has it and when they don't. And if I'm ever borderline, like, I'm not sure if you have it because there's other, and it's usually because other factors are influencing the diagnosis. So they may also have comorbid depression, for example, or anxiety disorder, or personality disorder, or bipolar, or something like that. Because remember, over 50% of people with ADHD have another comorbidity. And often I find if you treat the other thing, then what you'll find is you may or may not then still have a remaining diagnosis of ADHD.
Yeah, that's fair. I think in terms of, in a practical sense, as a GP, patients often do present and they say, I've done these screening questionnaires and it says there's a 90% chance that I've got ADHD, or they've scored so highly on it. And at that point, they just want a referral. Yeah. And even when if we do a deep dive into their symptoms, everyone knows the 3 cardinal features of ADHD. It's in the name. So it then becomes difficult because they often don't want, even we can do a deep dive into their symptoms. I mean, when I worked in community mental health, I was doing the initial assessments for people before we sent them for ADHD assessments by a psychiatry consultant.
Yeah.
But people don't want to hear it from a GP. And in our local area now, the service is just overrun.
Yeah.
And they've now said people can't be referred unless they can demonstrate severe mental health challenges off the back of off the back of a potential diagnosis of ADHD. So in practical terms, when patients come to me and they say, this is what the thing shows, how do you think we can have a conversation with them to say it might not actually be ADHD?
Okay.
We've gone right into the deep end. Sorry about that.
Yeah, no, that's fine. I think, to be honest, just hearing your question, I think what could be a helpful conversation is, rather than first getting to the point of you might not have ADHD, something I open all my assessments with is I tell people to park diagnoses. It doesn't matter whether they've come preempting ADHD, whether they think they have depression, anxiety, whatever it is. I say, forget about diagnoses, because I'm here to improve your quality of life and help you with the challenges that you have. Diagnoses are more like code for us, doctors, to know which cluster of symptoms someone might have, right? And then determine a certain treatment pathway, but they don't define a person. And so what I will open often with is, tell me your top 3 challenges. So I find that really helpful, because from that, you get more of a sense of, okay, where is it that I need to help this person? And what kind of things do those challenges come under? What kind of symptoms or disorders or you know, life events could those symptoms come under? And then I have a conversation with them about the impact that has on their life. You know, because one person could tell you they have really poor concentration, but it's not actually impairing anything in their life, and it's more that they've got a subjective experience of having poor concentration. You ask them, how long can you concentrate for? Sometimes it's way more than everybody else. They just have an unrealistic expectation. I sometimes get patients coming to my clients coming to my clinic saying, can you give me medication that allows me to work 15 hours a day at full performance? I said, no, I'm here to give you back your human health, not to turn you into a robot or a work machine, you know. It's actually helping you to gain work-life balance is part of my role as a clinician, not to get you to a point where you can drive and overdrive your body to a point where it's going to start to fragment anyway. So I think as a GP, that's probably a useful, or could be a useful way to address it, is rather than trying to find a way to convince them they don't have it, just try and get an understanding of what's actually going on with them in terms of what they're experiencing. Like 3 things, if I could improve them in your life, what would you ask me to improve? And what is the impact of those 3 things in your life? How does it affect things? Because then even if you're making a referral, your referral is more justifiable.
I love that. Talk about the challenges, the things that you would want to improve, and how it's impacted you. I think that's brilliant. I'm actually going to use that
Okay.
in consultations now. That's fantastic. And you're right. It would just instead of just running through symptoms and say, I don't know, did you feel like you lacked concentration and things like that, which is really subjective. Then we're actually then assessing. We're assessing them more holistically.
Yes.
Which I think is fantastic. Which is super, super, super helpful. So then we've not had any questions in the comments yet, so I'm just going to make a little shout out to everyone. Anyone in the comments who wants to, who's watching the live, anyone who wants to ask anything about mental health, then now is your opportunity to do that. I have a couple of questions that I had written down before this because I was prepared. So we had a brief chat the other day, and you mentioned there are various different types of ADHD. Would you mind just going into that with me?
Yeah, sure. I'm also conscious that I don't want this to turn into one of those videos that's taken as a masterclass in ADHD, because there is so much to it. Just, you know, understanding it through this conversation may leave people with, you know, gaps. But if you look at ADHD, there's 3 aspects, there's 3 core areas of symptoms. It affects your attention, it affects your activity levels, so hyperactivity, and then impulsivity. What does that refer to? Your ability to control the desire to act on a particular compulsion or impulse, right? So when we diagnose ADHD, people can either have a combined type ADHD, where they pretty much have equal proportions of hyperactivity, impulsivity, and inattention. Or you can have the 2 other types are where one of the other groups predominates. So you can have a predominantly inattentive type, or you can have a predominantly hyperactive stroke impulsive type. Now, we haven't split it into 3 categories because generally where people have a predominance, it'll be with a hyperactive stroke impulsive or predominantly inattentive. And I would say in the ones that gets missed the most is the one which is predominantly inattentive, because the hyperactivity, impulsivity, yes, it can be masked, but it does tend to show in, like, for example, now a lot of people are going to say, I've got that. You know, when you're sitting there and you're shaking your foot when you're waiting, right? That shows you're restless. That doesn't necessarily mean you have ADHD, but
that happens to me when I've had too much coffee.
So a lot of people have that when they're restless, they shake their foot. But where there's hyperactivity and impulsivity, I usually see some physical, even if it's not that, something else. Like when somebody has the predominantly hyperactive impulsive type, that even in adults, when I walk into a waiting room to get my client, it's almost like as soon as I see them, I'm like, okay, I think this person's, you know, even where they don't know they have ADHD and have come for a general psychiatric assessment, I'm like, I think this person's got ADHD. So yeah, I think those 2 types, it's important, those 3 types, sorry, is important to distinguish, because often you'll see that the certain types are easier to mask or miss.
Fair enough. That's perfect. Perfect. So we've had a couple of questions in the comments, which pretty good actually. So how do we help break the stigma for people who are scared to get medical help for their mental health issues?
You know what? I think this is a concern for everyone, not just clinicians. And I see that on social media, people are trying to address it. Unfortunately, I think that the number of people who are on platforms talking about mental health who don't have much experience or knowledge of it, but have kind of jumped on the trend because it gets them interest, followers, etc., far outweighs the number of people who actually have knowledge about it. And so what I've found is, rather than, yes, it's got people talking about mental health, but it hasn't got people talking about mental health in a balanced way. And so what I've found is there's I've most seen these polarizations. On the one hand, we have pathologized and medicalized really normal human experiences that everybody has, like, for example, sadness, worry. You know, they've been, people refer to them like anxiety and depression, but it's not. Sadness and worry are different to anxiety and depression. Being clean, for example, is not the same as having OCD. You know, being a little bit forgetful or, you know, not being able to focus for certain periods in your life doesn't necessarily mean you have ADHD. So how do we reduce the stigma? Because on the other hand, we're also seeing that those who do have severe mental health problems, their mental health problems have been normalized, almost like, oh, because everybody else is talking about it and everybody's talking about it, that means everybody must have it. But not everybody has a mental health problem. So rather than normalizing those things which actually are, you know, show signs of significant mental health problems, and pathologizing or medicalizing normal human experiences, I think one of the important things or important ways we can reduce stigma is just through this quality of acceptance, and acceptance not just of ourselves and other people, but understanding what we're accepting is really that the suffering that someone goes through, the challenges someone goes through, doesn't define them. Because I'll often have patients come and they will be very upset because they haven't got their family or friends on board. Their family and friends have often said this is not the same person, they're different, they're not who they are, and they may even reject them. But that stigma around, that's there in terms of having a mental health issue makes you less or makes you weak. It's got nothing to do with your character. Just like your body is vulnerable to disease, it's vulnerable to illness, so is the mind and the brain. And that is no reflection on the value of a person. That is no reflection on that person losing their sense of self. So I feel like the acceptance, but acceptance also that it should be a whole person's. Our mind and brain is part of us, our body is part of us. And just because the mind, body, brain can become impaired and create difficulty for us, it doesn't mean that we have lost ourselves or anyone has lost themselves. And I think conversations like that help reduce the stigma. Education around identity, who we are, where illness comes from, how also that mental health problems are not lifelong in the vast majority of cases. It's really rare to have conditions where the illness is lifelong, and even if the illness happens to be something that is lifelong, it's usually episodic. But like I said, it's extremely rare. So I think just considering some of these points to reduce the stigma can be really, really helpful.
Perfect. There was another question about someone who's been diagnosed with ADHD and they don't want to tell their partner because I think their partner is cynical of that kind of diagnosis. I think it follows on quite nicely from what you were just saying, because it suggests that there is probably still some stigma around ADHD. And there definitely is, because I mean you hear it on the radio when people say, oh, in my day it was just called a naughty child. How do we combat that as clinicians?
You know, where I have patients whose partners or loved ones are, or friends even, might be struggling to come to terms with it or might be dismissive of the condition, whether it's ADHD or anything else. You know, I also get it with personality disorders, even depression. You know, as much as people talk about depression, still in many families and couples, people will find that their partner doesn't, you know, get on board with the fact that there could be anything psychologically distressing, and it's all down to character and how much you can pull your socks up. So I often find what's helpful is if you're working with a clinician, see if you can do a joint session. Sometimes one joint session, bringing that loved one in to the session, can be really, really helpful, because the clinician's then able to reframe and answer questions and concerns that your partner or loved one might have. But yeah, there's lots of ways to tackle the stigma. But I think probably the most powerful way, you know, beyond education, beyond what the narrative is on digital media or in politics, is just care about people. Know that whatever suffering they're going through is not defining them, and give them the space to access the help they need, and yourself to be the best that you are and can be.
Yeah, I think that's really important, because if we don't accept people in those states, then it doesn't give room for personal growth, and even growth within a relationship either, which must be quite hard to deal with for people when they're in that situation. We have another question.
Okay, can I just make a point before we go to the
Yeah.
next question? Sorry, Suraj. I was just going to say, you know, for a lot of my patients, it can be really helpful when they do get a diagnosis, because what it provides them with is a framework to make sense of what they're experiencing, why they're experiencing it, and how they can move beyond it. Because, you know, I genuinely believe and see this all the time, that whatever crisis someone has, even a mental health crisis, it's there to point out to each of us whenever we have any crisis, that the way I was doing things before isn't going to work for me anymore, and something needs to change. So whether it's a financial crisis, relationship, physical health, mental health. And so love and acceptance is a really big part of that, having those nourishing relationships. And my patients who have nourishing, supporting relationships, regardless of what their diagnosis is, tend to recover much more quickly and have a more successful recovery outcome.
Yeah, I can completely see, you can understand why that would be the case. Earlier on, when we were talking about how ADHD can mimic, or some of the symptoms associated with ADHD can be, there's an overlap with lots of other conditions, in the same way that feeling sad doesn't necessarily mean that you're depressed, and feeling nervous doesn't mean that you have anxiety. How do you differentiate in clinical practice between people who are depressed and people who are just going through a tough time, or it's I don't want to say normal sadness, but there's
Yeah,
a
there's a normal
yeah,
sadness, a healthy amount of sadness. All our emotions tell us something, right? You know, even the uncomfortable feelings tell us something. They tell us what we like, what we don't like, who to trust, who not to trust. So we don't want to become numb robots, right? That's not, nor
true.
do we want to be just, you know, elated in this fixed place of elation. That's not good mental health. So mental health is a spectrum, just like our physical health is. Your regular aches and pains you can probably deal with home remedies. When they start to impair your functioning and become intolerable, that's when you go see a clinician, you go see your doctor, you go see a physiotherapist. So same with our emotional health, our psychological health. There are certain things which actually going for a run, going for a walk, eating well, sleeping well is enough to get things back on track. But if you're finding that your emotional and psychological well-being, your thoughts, the way you perceive things, have got to a point where they are intense, overwhelming, impairing your ability to do things that are helpful to you, impairing your day-to-day functioning, then that's the time to get help. And that's, as a clinician, really what I'm looking at is not just your experience, but what is the impact of that experience on your quality of life, on your relationship. So when I say functioning, I don't just mean work. I don't just mean education. I mean also, you know, how you relate to people and how you receive them.
It goes back to what you said earlier about the challenges that you're facing, and then the impact it's having on your life, and
Yeah.
what you're hoping to get out of a consultation, which I think is really important. I put out some questions to my followers on TikTok
Yeah, and we
a
have
little while
loads
ago.
here as
We
well.
have There are loads. There are loads in here. There was one that I was quite interested by, which I just wanted to read out. I'm in my 70s. I believe I'm dyslexic and have ADHD. Is it worth getting them tested? It's a lot of money to be tested.
It
Um,
is. If you go private, it can be quite a cost if you're doing both the ADHD and the autism assessment. I would say, coming back to this question, is, you're in your 70s. Everybody's different in their 70s. I meet people in their 70s who are like people in their 40s and 50s. They still have quite a lot of energy. And, they've got not just a lot of energy, but they're just strong physically, mentally, spiritually. They're high functioning. The age is just how much time has gone by in terms of how long they've been on this planet, right? So for them, in terms of, because they're still, very much not just high functioning, but living that high function, it may well be worth getting those assessments if they're finding that those things have impaired their day-to-day functioning and has consistently done so and been missed. But if you feel like, actually, yeah, I might have these things, but actually, my life is pretty much where I need it to be. I'm functioning the way I want to. I've got the quality of life and relationships that I've got. Then there wouldn't be much benefit in getting the diagnosis, because unless there's a need for the actual treatment or the need for any of the interventions, then it's not often worth doing. But so, for example, I have a patient at the moment in her 60s who's had lifelong challenges with mental health, and she's likely to be on the autistic spectrum based on my screening questions, and also having treated her. The benefit that the assessment would have for her now would be more about her gaining an understanding of how which traits she's got have impacted her life and her perception and her relationships, etc., rather than necessarily introducing some new therapy or new medication or new treatment, because she's now at a stage of her life that, actually, having lived her whole life, she's found her ways both through self-help, medical help, psychological help, and even her own self-work to overcome some of the challenges she experiences. So, I guess you've got to just ask yourself the question that, how much am I finding the symptoms of these are affecting me? And it's not so much about understanding whether you have the diagnosis, but would the process of getting the diagnosis and the treatment help improve your quality of life, or is it more like for interest only?
Fair enough. Um, my I disconnected briefly, so some of the questions I might have missed, but we've
Right,
got one.
I might go through
Go
some
for
of
it.
them, actually. So there's a couple of questions on it's quite a bit on functional neurological disorder and psychiatry. There's a good one here on people who have therapy say everyone should have therapy. What are your thoughts? Does everyone need therapy? If you ask someone, does everybody need physiotherapy? I don't think anybody would say that everybody needs physiotherapy, but I think most people would say you need some sort of physical movement and exercise, right? To feel healthy, to keep your body at its optimum. So if you look at physiotherapy, is the way somebody, if you've got, it particularly pertains to your muscular joint system, etc., your musculoskeletal system. So psychotherapy uses the framework of language, reflection, question, self-reflection, insight, emotional understanding, to help people to gain a better understanding of themselves, the way they respond to events, the way they see themselves, the way they see the world, etc. And there's so many different types of psychotherapy. Psychotherapy is a non-judgmental holding and processing space for us when we're going through either mental health problems or particularly challenging times in our life. Just like one may decide to get some physiotherapy if the aches and pains get to a point where they're like, okay, I know this isn't a sinister disease, but it's also not
impacting my life.
Yeah, it's affecting my life, and it's not enough me doing my basic stretching exercises. I need somebody who understands this a bit more. And your physiotherapist will often say, hang on a minute, I think there might be something else going on. Go see your doctor, get diagnosed. So similarly, I'll have psychotherapists who will send patients to me saying, look, I think what they're going through is more than just talking therapy on its own can handle. They need to get assessed and diagnosed. So coming back to that question, I think everybody needs non-judgmental, loving relationships where they can talk about their challenges and be celebrated for their successes. Where we don't have them, or there's a period of time where they're not so accessible to us, therapy can be that useful bridge and help you through a challenging time. There are some therapies we know work particularly well for certain conditions, but because there's so many different types of psychotherapy, when people say therapy, it includes psychotherapy, hypnotherapy, art therapy, drama therapy. There's so many different types of therapy. Even amongst the psychotherapies, the talking therapies, there's so many. DBT, CBT, schemotherapy, logotherapy, existential therapy. I mean, there's tons of them. That's why I generally recommend that you go and get an assessment first with a psychiatrist and find out if there is, especially the more severe your impairment is, get an assessment because you might need a particular type of therapy. But if you're going through general day-to-day life challenges and there's no one to speak to, then counseling or psychotherapy can work. But bear in mind, counseling is slightly different. Counseling is a space where there's no proactive work on a particular situation, but it is a holding space, sounding board, listening, and often for many people that's really, really helpful. Whereas psychotherapy is much more interventional usually.
So would psychotherapy is it in any way similar to something like cognitive behavioral therapy?
So cognitive behavioral therapy is a type of psychotherapy, right? Just like DBT, dialectic behavior therapy is. So it's integrative psychotherapy that uses different modalities. You've got interpersonal psychotherapy, you've got psychodynamic psychotherapy, you've got transpersonal psychotherapy. So they all use different models to understand the schema of our emotions, our sense of self, our place in the world. And they help us to navigate that. So does everybody need psychotherapy? No, I don't think everybody needs psychotherapy. But it should be accessible for people should they need it, especially if you've got you've either got a condition that needs the support of talking therapies, or you are going through a period in your life where those non-judgmental loving spaces are not available to you.
Okay, perfect. Were there other questions in there that you wanted to?
I'm just scrolling because right. Why don't you ask one of your questions while I'm having a read? Otherwise, all people are doing is staring at my face.
If anybody wants to retype any questions or ask anything else, please feel free to.
I think there was a question here about treating mental health issues and depression in a holistic manner, right? How do you treat depression in a holistic manner? How do you treat anything in a holistic manner? The word holistic means I've taken the whole person, right? And whole person means mind, body, their social relationships, their culture, their spirituality. And so just like in terms of, if you look at the causes of mental health conditions, it's multifactorial, right? All of these things, all of these parts of ourselves contribute to the development or the healing of mental health, physical health conditions. So when we treat holistically, we look at all of these parts. Like when we do the assessment, psychiatric history, it's we have this joke, right? We had this joke even we were training as psychiatrists, that out of all the doctors, psychiatrists are the only ones to take a proper history. But then we do also spend more time with the patient. So it's because we take the whole story. We look at the social history, the personal history, the pre-morbid personality. We even go into the forensic history, cultural beliefs, spiritual support structures, everything, drug and alcohol, past medical history, everything, we go into it thoroughly. So holistic means get the whole picture first in terms of assessment: what's causing, what's affecting, what's perpetuating, what's precipitating, what's maintaining the problems. And then piece by piece, you can look at in each of these areas, what are the tools that can help. So medication helps with the neurological and the biochemical side of the mind. Okay, breath work, meditation, your spiritual practices, they come from a place which is more metaphysical, right? And then the physiological things like movement, exercise, diet, adequate sleep, they also have a much more organic but physiological impact. So again, they're part of the holistic aspect of care. Improving relationships, improving finances, all of these things, they're part of holistic care. So yeah, I hope that answers that question.
I have a follow-up. So you're right about the psychiatric histories being supremely detailed. I remember when I was doing initial assessments for secondary care psychiatry, and 1 hour is the time I had for it, and it was not enough. And
Yeah.
now, considering that currently I work to 7 to 10 minute appointments as a GP, it wasn't enough, because as you said, you go into all of these different aspects of people's lives, and you really need to understand where things are coming from. And just following on from the like the fact that when you're trying to treat people holistically, when they are in a bad mental state, when their mental health is not where they would want it to be, often there's a lack of motivation to even want to do the things that would help them holistically, that we know will help, that are evidence-based. How do we motivate people to do things like going out for a walk, spending time in outdoors in nature, focusing on sleep and things that we know would hopefully help to improve their mental health, when there's a lack of motivation to do that because of their illness?
I think that's such a good point to highlight, that because of someone's mental illness, their motivation to do the things that help their mental health is reduced. So how do you improve that motivation? So if you look at people's motivation, conditions such as depression, they absolutely affect people's motivation. Okay, even those who have high functioning depression, they may still be going to work, etc. They will often feel anhedonia. They've lost the feeling of joy, even in the activities that they find usually pleasurable. They've lost the motivation. They feel flat. They don't feel like doing the things that they want to do. And at different levels of severity, they may function for the world up to a certain point, but then crash when they get home. And then as it gets more severe, they can't even function for the world. So it's extremely difficult, and I think an unrealistic expectation as a clinician of yourself and of the patient to try and persuade them to do the things that are healthy for them. It's better to actually start treating the depression. Okay, it's like asking, how can you get somebody who's broken their leg to start running the marathon? You wouldn't. You would wait for their leg to heal.
Yeah.
Right? So I wouldn't expect somebody who has clinical depression to have the motivation to do all the things that are really good for them, because actually often being able to sleep, get off to sleep and staying asleep throughout the night is impaired, in depression. It's often impaired in anxiety. So telling somebody who's depressed, hey, you really should be getting off to bed on time, they're going to be like, well, I try, but it takes me 4 hours to fall asleep. And once I'm asleep, I'm up every hour. That's not helpful to them. So this is what I mean by, I was talking about mental health being a spectrum. The more severe someone's mental health problem is, the more it's having, that's how you know you need help, is it's impairing the things that you would normally do to stay well, like your sleep, like your appetite. Oh, you really should be eating more, otherwise you're not getting enough nutrients to help your neurological health and stay happy. Well, I tried, but I have no appetite. I just feel sad all the time. I'm crying. That's what somebody with depression says, right? So actually, it's not about persuading them to do that. It's like, okay, it sounds to me like you have depression. Let's treat the depression. Are you open to medication and therapy? Do you want to just go straight into therapy? And if it's more severe, I generally say, look, I think you need the medication first, because you're so low. The time lag between you getting therapy, starting it taking effect is going to be a long time, and you may spiral and get worse. And often when people are very severely anxious and depressed, they often can't engage in psychotherapy anyway. So in that particular situation, as a clinician, I'm like, how can I pull them out of this acute state? So medication's one option. And then there are other things based on their past history, if it's recurrent, etc., or if it's treatment resistant, you may want to try other options.
I have a follow-up. Um, when people when people are severely depressed, it they can become psychotic, so they can have psychosis off the back of it. I've never really understood that mechanism. I have seen it in practice, um, but I don't get why that happens. And then in terms of treatment, people would,
Yeah.
depending on the severity of it, they usually need to be sectioned or need an inpatient admission. But from my experience, but I would just love to learn a bit more about that.
So the vast majority of cases of depression, you don't get psychotic symptoms. I find people are more likely to get the psychotic symptoms when they've had depression for a really long time and not had it treated. There's a higher risk of getting the psychosis. Now, what do I mean by psychosis? Because I'm very conscious that people listening may not have a clue what on earth we mean by psychosis. So we understand that depression affects your mood, affects your thinking. You get negative thinking, you get low mood, you may get emotional dysregulation. You may also get anxious with it, impairs your sleep and appetite. When we're talking about psychosis, with psychosis, what happens is your perceptions are often impaired. So by perceptions, that means even the way you see things, taste things, hear things. So you may have hallucinations. You may, in terms of perception, I also mean the way you put things together, the way you rationalize. So you may be experiencing delusions. So a common type of depression with, a psychotic component is where somebody might have delusions. Delusions means it's a false, fixed belief, which is rooted in an irrational logic. So you may have beliefs that are nihilistic. That means you feel like your body's rotting or you're dying. And you hold it to be so true, you start to live your life based on that. So this is what happens in psychosis. Your reality is impaired because your perception of reality is impaired. So it could include hallucinations, it could include delusions. And it is rare, and it's more likely the longer you leave depression untreated. But it is different to schizophrenia because it's not episodic. It is primarily mood and then secondary, some psychotic component. It responds really well to antidepressants and antipsychotics. But remember, with a depression with psychosis, often the antipsychotics are only needed for a short period of time, weeks to months, rather than months to a few years, which is more likely to be the case with schizophrenia.
Does the amount of time that someone is in that psychotic or delusional state impact their long-term outcomes? Or is it once we get that under control and treat the depression, things generally improve overall?
So with any mental health problem, I've generally found the longer you leave it to treat, the longer it takes to treat it, and you often need more intense interventions. Where psychosis of any type, whether it's coupled with a depression or whether it's a standalone psychosis or part of schizophrenia, the longer it's left without treatment, the more fixed the delusions can get, the more fixed the hallucinations can get, because the longer we are in a particular reality, the more real it becomes. And so then whether we're using just medication or medication and therapy together, it just takes that little bit longer and that little bit more intensity and frequency of, reviews and interventions to get them out of it. But, certainly I've always seen improvement. I've not ever had a patient who hasn't improved once intervention has started. And once treatment has started.
Okay. And how often, or if ever, would someone in that situation need something like ECT?
That's extremely rare. It's
Really? Okay.
very, very, especially these days. We've got such good treatments now, and people are becoming more aware of their mental health problems and accessing treatment earlier. So the earlier you get treated, the less likely is you're going to get into a situation where you need to be treated with ECT, less likely to need sectioning, etc., less likely to have a lifelong illness, less likely to have recurring episodes. So this is why I'm like, let's talk about mental health in a way that it encourages people who have mental health issues to get help, and those people who have the experiences within the remits of, good mental health, maybe things are getting a bit wobbly, can use self-help techniques to come out of it and to get people, who actually need solid interventions, treatment, access to it quickly, so that systems are not clogged up with people who are the worried well.
Yeah, I understand that. That's perfect. Are there any questions in here that you want to answer? Otherwise, I've got one final one before we probably call it an evening,
Yeah,
because
no,
this was only meant to be 30 minutes and we're approaching an hour.
yes. Yes, there is one here. SSRIs first make you feel worse before it gets better. Is the impact of that bio-individual, or is there a general time period when one experiences before they get better? I'm not sure where you've got this impression that SSRIs make you feel worse before they make you feel better. That may be your personal experience or maybe something you've heard, but that's not typically what people find. What you may be referring to is sometimes with antidepressants, not just SSRIs or any medication, you may be experiencing the fact that the medication hasn't kicked in yet, so your original symptoms are there, plus you may be getting some initial side effects, the mild ones that you get for the first week or two but tend to pass as the body adjusts. And when you've got your own mental health challenges plus the side effects of the medication, that can feel like things have gotten worse before they get better. The other thing that can feel like things have gotten worse before they get better is because you're talking about the things that have, been affecting you, whereas before you've probably kept them buried. And sometimes when you bring it to the surface, you've got to face up to feelings and challenges that you didn't before. And so that can also make you feel a little bit worse before you feel better. So I would say, just like with physiotherapy, when you first start rehab, it hurts sometimes more than it did before you started the physio, because the pain was buried, right? And was only episodic, whereas the physio is kind of pushing things out, picking out the sore points. Even a massage, I went for a massage a couple of weeks ago, a therapeutic one. And to be honest, the 2 days after I had the massage, my body hurt more than it felt better. But then the days after that, I felt better again, because that massage, it brought the deep-rooted knots and stress to the surface. So it's not necessarily always the medication that makes you feel worse before it makes you feel better. And also remember, especially with antidepressants, there is a time lag between starting it and getting the benefit, which is about 2 or 3 weeks, because you're not just, antidepressants don't work in such a way that they're putting a new substance in your body. What they're doing is they're working with your own natural biochemistry, your natural neurochemistry, and adjusting it in such a way that it optimizes your own natural neurochemistry. So it's not just got to get into your system, it's got to get to a level which then crosses the blood-brain barrier and then affects change. So that can take a few weeks.
Interestingly, though, in practice, we see people after a week feeling so much better.
Yes.
And it's interesting that you say that there isn't really an effect of it making you feel worse, because I've always been taught that it does. So I do caveat my patients, and I tell them that there are, in a minority of people, it can make their anxiety worse.
Yeah.
It can increase the risk of self-harm in certain people. So we instead of doing a normal follow-up after 2 weeks, in some high-risk patients, we would follow up after a week, just so we've got something in the diary so that they know they're not alone.
But the thing is, I think the important thing to remember with that is the minority.
Yeah.
And like I said, the rebound anxiety you might get with certain types of medication is, again, it's the body adjusting. It's kind of like with antibiotics, you don't see the results straight away, but you may get the upset stomach. And it may make you think, flipping heck, as well as my aches and pains from the infection, I've now got an upset stomach. What's the point of these blooming antibiotics? And then eventually they kill off the bugs. So medication can often be like that. Yeah, I mean, definitely the things need to be reviewed. You've got to tailor the treatment plan for what suits the patient. But I always caution against changing things too quickly, because that can also disrupt things. Say to people, fine, let's drop the dose and ease into it slower, but not just stop it completely. Unless, of course, the side effect or experience is so unbearable. But this is where we are patient-led. I think we have time for one more question, and then we should stop.
So,
we could talk for hours.
We actually could, and we knew that this might happen. So SSRIs, how do you know if you should come off them? I feel too nervous to try and come off them. from my experiences, we always say that you need to have been stable with your mental health for at least 6 months before we start considering a wean. And actually, my follow-up question from that is, what would be your recommended way to wean people off antidepressants if we determine that they are completely stable? How do you recommend that we do it? And in what situations?
So I'm going to go back to the first question that was asked by one of the viewers, is how do I know I'm ready to come off? So just to echo and to add to what you were saying, when you're on medication for mental health, it's like a splint, right? You break a leg. When you break your leg, a plaster cast is put on it. And it's the plaster cast doesn't actually heal your leg. The healing's going on from inside, right? Your body's healing from within. But what the plaster cast does do is it keeps things straight so that your bone heals straight. So often with antidepressants in particular, what they're doing is they're lifting the symptoms that are stopping you from doing the things that help your mental health to be at its optimum. So your eating becomes regular, your sleep becomes regular, your mood lifts, your thought processes become more close to your usual style of thinking, much more positive. And alongside that, doing the work, whether it's more movement, eating healthier, taking to your spiritual practices, journaling, having psychotherapy as well to reflect and process on past experiences. Those do some of the more deeper work in terms of bringing things back to a balance. So then when you remove the antidepressant, it's like you're just cutting the plaster cast off and the bones healed nice and cleanly underneath. This point of you've got to be well for 6 months before we stop. So medication also has a role in preventing another episode. And we say that people are most vulnerable to relapse in the first 6 to 12 months after feeling their optimum. Now, often what people will do is, oh, I feel all right now, can I stop the medication? Like, no, just stay on it at least for 6 to 12 months more, because it's got a role in preventing relapse, right? Just like even if your bone heals, you might still wear a boot, or you might, have something, you ease into your activity.
I'm loving these analogies, by the way.
So it's because it's easier to understand the body in some ways than the mind. So it just plays, it's a really good analogy. So but if somebody's had recurrent depression or has had it for a longer time, I often have them stay on the antidepressant for longer. So this is why it's important to have active involvement from your psychiatrist or your GP. Whoever's prescribed the antidepressant should be actively involved and regularly. It's not a decision you should be taking on your own. So Suraj, your last question was, how do we wean people off? Okay, so now remember, weaning gives you some sense that, oh, I've become addicted to medication. That's one of the things that cause stigma. Addiction means you've developed a tolerance and you need increasing amounts to help you have the same experience, which is what you get with drugs, which is what you get with any addictive substance. Medication is not inherently addictive. So people don't find that it stopped working because I'm tolerating it, or that I need more and more and more and more because it's not effective. That's not how they work. But if you stop them abruptly, you can get something called a discontinuation syndrome. You might get experiences like, dizziness or feeling sluggish, or you may feel agitated, or you may get brain zaps. It depends on which medication you're stopping. A lot of this is to do with the half-life of the medication, how it's metabolized in the body. Okay, so medications which have a long half-life, that means they reach half the original amount in quite a significantly long period of time. So you look at something like fluoxetine, has a half-life of 5 days, right? If you stop it abruptly, it takes 5 days for it to reach half the level. So people don't often get withdrawal symptoms, or sorry, withdrawal's not the right word, discontinuation symptoms with fluoxetine, because it's got a long half-life. With most of the other antidepressants, especially the ones you take twice a day, they have a much shorter half-life. So if you miss a dose, or you miss a day, or you miss a couple of days, you are more likely to get the discontinuation syndrome. So in most cases, the longer someone's been on it, the longer we take to taper them off it. Because it's kind of like, if you were to even give up sugar, if you did it abruptly, you're probably going to get headaches, etc. the first few days. Not because you're addicted to it, but because your body's adjusted to a certain amount of sugar in the body. And so you get this kind of discontinuation effect. So yeah, it's about, because your brain neurochemistry needs to then find its feet again. right?
Yeah.
Once you take away the medication, it's then got to the neurochemistry's all got to rebalance again. So yeah, that's my 2 cents worth on weaning off. Do it slowly and do it under the guidance of your prescriber. But it's been really great talking to you, Suraj,
Thank
and I'm looking forward to
you.
doing the next one.
Thank you so much, Dr. Chetna Kang, consultant psychiatrist. Thank you so much. This was brilliant. Thank you, everyone, for sending in your questions. And we will do this again. We just need to find another time.
Fabulous. Okay, speak to you all soon. Take care.
Thank you.
Bye, Suraj.
Bye-bye. Bye.